Welcome to the video presentation, Highlights from ASH, a Canadian Perspective. The content for this program was developed entirely by the faculty based upon their review of the thrombosis presentations at ASH. Thrombosis Canada would like to thank Sanofi for the unrestricted grant to support our development and delivery of this program. Tonight's presentation is chaired by Dr. Marc Carrier, Secretary of the Board for Thrombosis Canada. Dr. Carrier is a professor of medicine at the Faculty of Medicine of the University of Ottawa and senior scientist in the clinical epidemiology program of the Ottawa Hospital Research Institute. He is the hematology division head at the Ottawa Hospital and holds a Tier 2 research chair in venous thromboembolism and cancer from the University of Ottawa. Thank you, Dr. Carrier, for chairing tonight's program.
Thank you very much, David. It's a great pleasure today to have a discussion on a quiet Wednesday afternoon on highlights of ASH. And we were really well represented at ASH this year. A lot of Canadian speakers, lots of Canadian data. So we'll try to give you highlights of ASH, but with a Canadian perspective. And so 4 of us went to different sessions during ASH and trying to combine the data together. So I'll introduce them more formally when they're speaking, but Dr. Vicky Tagalakis, Dr. Cynthia Wu, and Dr. Jean-Philippe Galanaud are part of the faculty that did this program for us tonight. And this program has received financial support from Sanofi in the form of an unrestricted educational grant that was provided to Thrombosis Canada, and the presenters have received payment from Sanofi through Thrombosis Canada for the product may be discussed during the presentation, and Sanofi may benefit from the sale of the product enoxaparin that may or may not be discussed during this presentation. Okay, and for today's presentations, we have decided to come up with 4 different topics. The first one will be primary prevention of cancer-associated thrombosis, and I'll entertain you for about 15 to 20 minutes on that, and then Dr. Cynthia Wu will discuss bleeding management. There's a lot of data. Dr. Deborah Siegel did an educational session on this, so a lot of exciting new stuff. Then Dr. Vicky Tagalakis will dive into perioperative management. There's been a lot of Canadian perspective with the POSE study that was recently published, a lot of post-hoc analysis, so maybe giving us a little bit more insight on how to manage the directal anticoagulant in that setting. And finally, Dr. Jean-Philippe Galanaud will be reviewing the VTE guidelines on the prevention and treatment. And we were well represented again because Dr. David Anderson from Halifax presented the VTE guidelines on prevention of VTE post-surgery. After attending this program, we want to have 4 or 5 objectives. The first one will be having a discussion about primary prophylaxis and discussing the risks and benefits for ambulatory cancer patients undergoing chemotherapy. We'll present bleeding management. We'll have a discussion about perioperative management of direct anticoagulants and vitamin K antagonists. And we'll review the key recommendations for the prevention of VTE post-major surgery and the optimal anticoagulation management following a VTE. So let's start with primary prevention of cancer-associated thrombosis. We all know that VTE can be common in the setting of cancer patients. Just having a diagnosis and then initiating chemotherapy increase the odds of having VTE complication. It's associated with increased morbidity and mortality in patients. So it makes sense that clinicians or medical oncologists, hematologists, internists, and other healthcare providers might be wondering, should we use primary prevention for cancer-associated thrombosis? And there have been a number of trials that have been published on this topic in the past, and looking at different intervention, different types of blood thinners, different types of dosing, but also different patient population. And the first abstract that we looked at is looking at specifically lung cancer patients. So it's primary thromboprophylaxis, real-world data in lung cancer, but also looking at a systematic review meta-analysis specifically in that tumor type, and looking at all the previous studies that have compared parenteral thromboprophylaxis. So we're looking at low molecular weight heparin, and in some cases simulparin as well, that used to be an ultra low molecular weight heparin, very similar structure, and comparing patients that receive the intervention versus placebo for observation over time. And this is a way to try to, homogenize the patient population, trying to see if we do an intervention with patients that have locally advanced or metastatic lung cancer, what type of result do we see, trying to pool the data from the different studies. And what they've shown is that when you look at primary prophylaxis, you're actually leading to a relative risk reduction of about 50%, the number needed to treat is only one to prevent VTE from happening. Obviously, on the flip side, you always need to look at bleeding, looking at pharmacological parenteral thromboprophylaxis with low molecular weight heparin. There's a slight increase in the rate of major bleeding complication, but that was not statistically significant. And the absolute rate was also very small. So again, this is the data looking at previous studies, but really putting the basis on the fact that primary prophylaxis is effective. We can homogenize patient population. You can have a discussion about should we stratify patients according to tumor type? Should we stratify patients according to other factors? But at least the basis to understand that we can identify higher risk subgroups of cancer patients that may need thromboprophylaxis. An intervention with low molecular weight heparin seems to be very effective and not associated with increased risk of major bleeding complications. Now, there's different ways to stratify patients according to their underlying risk of having VTE. One of them could be, for example, using the tumor types as we just saw, but it could also be using a clinical prediction rule like the corona risk score, for example. That might be a way to stratify patients according to their risk. So there's real-world data as well that has been published, because the corona risk score, you may be familiar with it, but it's a score that stratifies patients according to their underlying risk of having VTE, using the tumor type as we just saw, but also CBC parameters like white blood cell count, hemoglobin, platelet count, and the body mass index. And that's stratifying patients according to their risk. If you have 2 or more points, your risk of having VTE complication is probably around 10% at 6 months, so this is huge. And it might be helpful for clinicians to know which patients might be at higher risk, right? One of the things that often we wonder is, well, that's working fine and handy in some randomized controlled trial, but is it applicable to patients we actually see in clinical practice? And when we saw this oral presentation as presented, I thought it was interesting because it also reflects that patients that are receiving or that can be stratified according to the underlying risk of VTE may be actually the same in clinical practice. So this is an analysis that was done in a community setting in the United States, and you can see the baseline characteristic on your left-hand side, and the proportion of patients with VTE according to the underlying risk of corona risk score was really, really similar to what we see in the validation cohort study and in the clinical trials. So I thought this was interesting because it's applicable not only to clinical trials, but it seems to be applicable to patients in the real world as well. And it's reassuring when you're trying to do an intervention, saying that whatever you see in randomized controlled trial may actually be applicable in the clinical practice in patients we see all the time. So in that particular abstract, the corona risk score was able to predict the risk of underlying VTE in unselected patients using a large database in the United States, and I thought that was pretty amazing that we could do that. Now, obviously, when we stratify patients according to their underlying risk of VTE, then the next question is, should we provide them with an intervention or not? We need to balance the risks and benefit of thrombosis compared to the risk of bleeding from the intervention. When you actually do the risk stratification, because the risk will increase over time, and throughout the cancer journey, this is a very, very common complication that we see all the time. So if the question is, should we do risk and benefit, then the next question is, well, we saw that parenteral thromboprophylaxis seems to be effective. Can we have the same result with the rectal anticoagulants? And the reason why I'm showing these slides is that there is also an educational session specifically on what's new for primary prevention, cancer-associated thrombosis. And over the past 6 months, there's been 2 randomized control trials, one that is Canadian in nature, so providing a little bit of a Canadian perspective. These 2 trials were double-blind randomized control trial, randomizing patients deemed to be at a high risk of VTE based on a coronary risk score of 2 or more, and randomized to a rectal anticoagulant. So it'd be apixaban 2.5 milligrams PO BID for AVERT versus 10 milligrams PO daily for Cassini or placebo, and then patients were followed over time. The big difference between the 2 trials from a primary outcome measure is in the Cassini trial, patients needed to have bilateral leg ultrasound before randomization. If they had any clots there, they were excluded, they were not randomized. And then patients were followed with Q6 weeks ultrasound during the trial conduct. So you can see that their primary outcome measure is slightly different because they not only include symptomatic VTE and incidental PEs like in AVERT, but also include screening detected deep vein thrombosis and distal symptomatic deep vein thrombosis. The safety outcome was the same for both trials. It was major bleeding based on the ISTH definition. Now, when you look at the patient characteristics, the age was very similar. There's more women in AVERT because a lot of patients had gynecological type of tumor. So it's interesting because we use the coronary risk score in these trials. There's different tumor types that were randomized and therefore different baseline characteristics for the 2 trials. So I think it's interesting, but also complementary in nature. So the most frequent tumor types for AVERT were gynecological lymphoma and pancreatic, and 50% of folks in Cassini had gastrointestinal type of tumor, and a third had pancreatic tumors. In both trials, 2/3 of patients had a coronary risk score of 2, and the rest had a coronary score of 3 or more. So when you look at the final result of the analysis, when you look at AVERT, the modified intention to treat analysis, the first thing you can see is, and I just want to emphasize the placebo arm for a minute. So when you follow these patients deemed to be at high risk for the coronary risk score and provide them with placebo, 10% of them will have an event within 6 months, which is a very high threshold. And if you provide them with thromboprophylaxis, in that particular case, apixaban, that will decrease it to 4%. So an absolute difference of 6% for a number needed to treat of 17, which is quite appealing. Obviously, we're giving a blood thinner, so we're increasing the risk of bleeding a little bit, and that's why we'll have to do a good risk-benefit ratio in order to consult patient in what to do or not to do. And that was associated with an increased risk of an absolute difference of 1.5% for an hazard ratio of 2, and a number needed to harm about 59. There's no difference in clinically relevant bleeding. The on-treatment analysis for AVERT, so on-treatment analysis means that we just included patients that were actually taking the tablets, the apixaban or the placebo, trying to illustrate what's the absolute increase or incremental risk of bleeding by taking a blood thinner. And you can see that when you look at major bleeding, the absolute difference in bleeding by taking a blood thinner was about 1% for a number needed to harm of 100. And then when you're at patients that are actually taking the tablet, they had a very low risk of VTE. The hazard ratio, the relative risk reduction, was close to 90%. So it seems to be working very well. On the Cassini side, when we look at the primary outcome measure, the intention to treat, they didn't reach statistically significant difference, but when they looked at the on-treatment analysis, they saw an absolute difference that was statistically significant. And when they combined the VTE and overall mortality, then they saw statistically significant in folks that received thromboprophylaxis with rivaroxaban. Again, on the on-treatment analysis, as I mentioned, they saw an absolute difference of about 4%, a hazard ratio that was 60% for a number needed to treat of 26. And the major bleeding is very similar to what we saw with AVERT, with an absolute increase of 1% for a number needed to harm of 100. So in that particular educational session, there was an emphasis on what's the right risk-benefit ratio and how should you consult patient about it and what should you do. Obviously, when you look at both studies together, they seem to have, thromboprophylaxis using directal anticoagulant. Or if we're extrapolating from the abstracts in the previous studies that I've shown you, low molecular weight heparin seems to be very effective. There's different tumor types. You can select a certain tumor type if you deem them to be at high risk, or using a corona risk score of 2 or more seems to be appropriate and seems to be effective. How do we translate that into clinical practice? Well, because the corona risk score has been validated with an intervention now with these 2 clinical trials, we're saying, or the speaker was saying, well, maybe you can use a corona risk score, and if you have 2 points or more, then you consider using thromboprophylaxis with either apixaban 2.5 BID, rivaroxaban 10 milligram once a day, or low molecular weight heparin based on the discussion we had with the previous abstracts and the previous data. Now, which one to use will be somewhat similar to what we have discussed in acute treatment trials. You need to weigh the risk and benefit and bleeding, and that's how you tailor anticoagulation in that specific patient population. Now, you may be wondering, is this a cost-effectiveness intervention? Is it worthwhile from a societal point of view? And these are the 2 last abstracts from my session. I thought they were interesting because they give 2 different perspectives. The first one from Hank Lee and colleague from Seattle. They did a cost-effectiveness analysis of different types of treatment for cancer-associated thrombosis in the setting of prevention of cancer-associated thrombosis. And you can see that doing these interventions using enoxaparin or directal anticoagulant for primary prevention cancer-associated thrombosis was deemed to be effective. And when we have a Canadian perspective, Dr. Kipton provided a cost-effectiveness analysis comparing or using the data from the AVERT trial and really looking at the intervention from a societal point of view, using different scenarios. So looking at 1 year of thromboprophylaxis with apixaban, or 6 months of apixaban, but a time horizon of a year. And no matter how you put it, the intervention seemed to be cost-effective overall. So apixaban or primary prevention seems to be associated with a lower health system cost overall when you're doing it, because you're preventing VTE that may lead to associated morbidity, mortality, hospitalization, delays in chemotherapy. And therefore, that might be something that we want to look for in the future. And I thought these were interesting because they're new data and puts a different spin or different perspective on primary prevention, that particular setup. So obviously, there's always patient education material. I know you're familiar with Thrombosis Canada educational material. I use it all the time in clinical practice. There's one specifically for cancer-associated thrombosis, so providing signs and symptoms, trying to create awareness a little bit. And unfortunately, when there is a PE or DVT, we also have patient information material for that as well. And that might be helpful for a patient to understand the underlying disease. So unless there's a burning question, because I'm also chairing, what I'll do is I'll triage the questions as the other speakers are going along. And if that's okay, in the meantime, we'll move on to the next speaker, and I'll generate discussion after Dr. Wu's talk, and at the end, we'll have lots of time for questions as well. It's a great pleasure to introduce Dr. Cynthia Wu. Dr. Wu completed her medical school and internal medicine residency training at the University of Alberta in Edmonton. She then went to complete the hematology fellowship for 2 years and thrombosis fellowship for 2 years at McMaster University in Hamilton. Obviously, she has moved back to Edmonton and currently is an associate professor in the Department of Medicine, Division of Hematology at the University of Alberta Hospital. Her research focus is venous thromboembolism with special interest in cancer-associated thrombosis. She's also the current director of Cancer-Associated Thrombosis Clinic, which runs out of the K Edmonton Clinic that she created in 2014. She's also the director of the Thrombosis Elective Rotation for Trainee. She's a great speaker, and it's a great pleasure to have Cynthia with us tonight that will be discussing rectal anticoagulation, bleeding management.
Hi, everyone. Thank you for that very kind introduction, and thank you to everyone who gave up their Wednesday evening for this. My topic is probably going to be a little bit more expansive than just DOAC bleeding management, but it's overall, we did find there was a theme on a lot of anticoagulant-related bleeding questions at ASH, and so I tried to consolidate all that together. So I gave a little bit of an overview because it is a bit of a hodgepodge, just so to orient people. I'll talk a little bit about some of the impact of underdosing anticoagulants, although it may not be directly related to the other abstracts. It was brought up in a few sessions, even including some of the introductory slides by Dr. Jeff White from McMaster when he was giving one of his special session talks on the new factor inhibitor drugs that are out there. And then I'll review some of the bleeding risk abstracts that came out. They were mostly in cancer patients because they are certainly the most complex and high-risk patients. And there are a lot of unanswered questions in this population. And then I will take from two different educational sessions, one by Jean Connors in the United States and one by our local Deborah Siegel, also from McMaster, looking at managing bleeding and clotting risk and also managing patients who develop major bleeding on anticoagulation. So if I start with a few of these slides that are a combination of one of the educational sessions as well as from Dr. White's presentation, I think we are very happy now that we do have these direct oral anticoagulants available on the market. They have addressed a lot of the bleeding risk problems that we have found with warfarin, but they don't eliminate bleeding. They do decrease the risk of major bleeding, particularly the most serious kind of bleeding such as intracranial hemorrhage, both for atrial fibrillation patients and DVT and PE patients. But unfortunately, despite this, major bleeding still remains the main complication associated with anticoagulant therapy. And GI bleeding in particular is one of the ones that has mixed ups and downs with the DOACs compared to the vitamin K antagonists. And certainly even in cancer patients, while I won't have time to review all of those data, you may be aware of the cancer-associated thrombosis trials of DOACs and GI bleeding still being a major problem. Because of that fear of bleeding, we do know that on surveys of physicians, physicians tend to overestimate the risk of bleeding and underestimate the risk of thrombosis, leading to underdosing or underuse of anticoagulant therapy. And with these low-dose DOAC regimens, it's even easier just to give people kind of a lower or intermediate dose, which might not be appropriate or guideline-based. Some studies have looked at trying to figure out what is the split of people on low and high dose and what the potential implications might be. So you can see from these pie charts, I know they're a little small, but you can kind of see that there are a large chunk of people who are on the lower dose of anticoagulant therapy, which seems to vary somewhat between countries, but certainly would probably represent higher than what we would predict the actual population that qualifies for dose reduction is. And if we take a look at some registry data, I know there's a lot of numbers and colors on this slide, but if you, to orient you, if you take a look at the bottom part, the pinkish, reddish color on the bottom, it shows people who are on vitamin K antagonists with or without antiplatelet therapy, which is decreasing over time as the DOACs become more popular. The little blue box in the middle is the DOACs plus or minus antiplatelet therapy, which is growing over time. But probably still the concerning thing, while improving, is still at least 30% of patients with atrial fibrillation who qualify for treatment are not on an anticoagulant therapy. So they're either on an antiplatelet therapy or nothing, which is still something that we can certainly improve upon. There's no time to show every study that has been published in looking at people who are underdosed or people who are on the low-dose regimens of treatment, but there's certainly been increasing numbers of cohorts of patients published in both atrial fibrillation and in VTE, looking at what happens if you're not using standard dosing of anticoagulant therapy. And while not all studies will show significant tendency one way or the other, there are quite a large number of them that will demonstrate that there's a higher risk of recurring either arterial thrombosis in the AFib population or venous thrombosis in the VT population if we're not dosing our patients correctly. So with that, I'm going to just segue into some of the higher risk bleeding populations that give us a lot of headache. There were two posters that try to outline a little bit more what happens to the patients who have intracranial tumors. So we know that having the tumor itself increases your risk of intracranial hemorrhage. If you develop a blood clot on top of that and then need to be anticoagulated, there's a lot of situations that patients are either not anticoagulated properly, or there's this fear that if you anticoagulate too aggressively, then you will provoke more bleeding. So it is nice to have larger centers publish as much data. I know this doesn't look like a large number, but for the group of patients we're looking at, not the most common tumor type and certainly a hard population to study, the more data we have, the better equipped we are to make our decisions. So this first slide just takes a look at the different types of brain tumors that were enrolled into this study, or followed, I should say, in this study, that showed that there were some patients with primary brain cancers and others with metastatic brain cancers. These were all patients who had some kind of venous thromboembolism, and then they were looking at anticoagulation reinitiation and what happened to the patients. So to make a long story short, as a whole, they found that people who restarted versus not restarted anticoagulation, there was a little bit of a difference, sure, but it wasn't a massive difference in the amount of intracranial hemorrhage that happened between the two arms. But if you take a look at the box beside that, you can see that there's a statistically significant 4 times increase rate of recurring VTE in the patients who do not restart their anticoagulation. And this was even in patients who receive the filter, which we know in cancer patients can be very complicated, and foreign material in a highly thrombogenic state tends to clot. And so we're looking at patients who unfortunately also got filters in this tough situation and then clotted, mostly in the lower extremity, probably as a result of a combination of things, including the filter. So balancing those high risks on both sides is a very difficult decision. But I think this slide shows that probably the majority of patients who could at least consider restarting anticoagulation despite the worst case scenario of getting an intracranial hemorrhage while on it. They did say that there are some caveats. They found in their kind of small subgroup of a very small group of patients that it was probably closer to maybe 15% instead of that like roughly 5% risk if you start it with a major intracranial hemorrhage. So certainly the bigger the bleeding event, maybe the more cautious you need to be. But they didn't split out specifically in this category what the clotting risk was. And we certainly know that brain tumor patients are at one of the highest risks of clotting. So it doesn't answer all the questions, but it gives us a little bit of comfort that maybe restarting anticoagulation, even in this tough situation, might not be a bad idea for a lot of these patients. The second study, which was also a poster, took a look at just patients who had metastatic brain tumors and the risk of intracerebral hemorrhage with or without anticoagulation, not necessarily people who bled on anticoagulation and then restarted. And this table has a lot of figures in there, but just really outlines again what types of cancers were involved, and overall there was nothing shocking in terms of the demographics of these patients. If you take a look at this graph here, it shows that, so the blue line is the patients who did not receive anticoagulation, and the red line is the patients who received anticoagulation. And the first half, I believe it would be your left-hand side of this graph, shows that the overall survival was not different between people who resumed or did not, or started, I should say, or did not start anticoagulation. But the other side shows that if you did develop an intracranial hemorrhage, not surprisingly, your mortality was higher than the patients who did not develop an intracranial hemorrhage. But they also overall concluded that, again, you should not categorically exclude all patients with brain tumors from anticoagulation, because even if there was possibly a slightly higher risk of intracranial hemorrhage, survival didn't seem to be vastly different. But you should select out patients because there are some types of cancers that are more vascular with a higher risk of bleeding, and for whatever reasons, men seem to have a higher risk of intracranial hemorrhage as well. I don't have all of their comorbidities, but it's possible that maybe they had higher cardiovascular risk factors, but it's speculation at this point for me. So certainly the combination of both of these posters would suggest that, again, we should not categorically exclude all patients with intracranial tumors from anticoagulation or re-anticoagulation, but more data would be required to select out probably the right patient who is the safest and has the best risk-benefit profile. Something that I found interesting is there is a Certainly growing data in the cardiovascular world looking at the combination of antiplatelet therapy and anticoagulant therapy and the so-called dual or triple therapy, whether we need it. And we're certainly starting to peel away, if we can, antiplatelet therapy, or at least limit the duration when you're on dual or triple therapy. And this group of investigators took a look specifically in polycythemia, whether they could start to assess the risk-benefit profile. And we know that polycythemia patients are at risk of getting arterial and venous events for prophylaxis before you get major events. We're already putting people on aspirin. So the question comes up frequently, if you now need to add anticoagulation, should you take the aspirin off or should you leave it on there? And so this nicely demonstrates, probably not surprisingly, that even in this population, if you add the two together, you do get a significantly higher rate of bleeding. Unfortunately, there was not a lot of things they could comment on the thrombotic rate because it was pretty low, so we don't have a very clear balance between the two, but it is encouraging that it was low, so there probably wasn't a massive difference in the rate of thrombosis, but the bleeding rate might be something more important to consider. So while it's not a randomized trial and it may not be the most definitive of answers, I think it is something that we need to think about, trying to avoid duplicating or adding additional antithrombotic therapies to these patients if we don't think that it is necessary. So thrombocytopenia was not presented specifically in major abstracts this year, but in an education session by Dr. Connors, it was mentioned because it certainly is complicating a lot of our cancer patients. They're also excluded from clinical trials if you have a platelet count less than 50, so we really don't have a lot of data out there. But this is just a reminder of what expert opinion has recommended in terms of guidance for patients who do have a low platelet count. And we put it in here because as the DOACs start becoming more and more used, particularly in cancer after the last two randomized control trials came out, there was really, as far as I could find in the protocol, no way of dose adjusting or stopping or doing anything for DOACs if the platelet count fell below 50. But there were some protocol for low molecular weight heparin adjustments if the platelet count went under 50. So it's, to me, still a little bit nerve-wracking to use a DOAC in patients where either they start with or you expect them to have severe thrombocytopenia, just because we don't really quite have the experience, and the half-life is longer, so just stopping it temporarily doesn't really give you as much flexibility as low molecular weight heparin. So something to think about in the background until we know better. So Dr. Connors also mentioned in her session, which I think was useful, is sometimes it's hard to actually balance the two, the risk of bleeding versus clotting. You can't just count up the number of risk factors on either side. Sometimes you don't really know exactly what the percentages are going to be in the net calculation you're trying to make in your head. But she did say maybe rather than a full balance, you at least just want to prioritize in your head which one is the highest priority. And she gave a little bit of an outline on what of these risk factors would potentially be of higher risk versus ones that might be of lower risk. We know that in the VT world, the time to the blood clot is certainly one of the biggest predictors of whether you're thrombogenic or not, whereas the first few days to weeks is by far and away the highest risk, and then risk starts to go downhill over time. The severity of the blood clot as well, or the location, is certainly a deciding factor too, such as if it's distal versus proximal, superficial versus deep, and so forth. So that can play a role in what you're going to do with your patients as well. For bleeding, there's a lot of things on this list, but probably very logically, are we looking at whether it's a permanent or a temporary risk factor, and whether you can actually find and treat the source is probably one of the most important things. And then how severe is the blood clot, which is, or the bleeding, which was certainly alluded to in one of those intracranial hemorrhage papers, where the larger the bleeding event, the more severe the recurrence risk was. So she concluded that certainly if you can't balance everything, you probably need to start prioritizing at every given point when you're assessing your patient which one is the bigger risk. And then you make your decision on that. And also recognizing that this changes, especially from a timeline perspective, and you just need to follow the patient very closely and make a new decision every time you see them to see if their priorities have shifted and whether you can either restart or increase the dose or maybe stop anticoagulants if bleeding risk becomes higher over the course of time. And it becomes one of those mobile models where you have to really involve and educate your patients so they can inform themselves and you of anything that is going on from a day-to-day basis. The last section that I'm going to do is taking a few of the slides from Dr. Siegel's talk, her education session on management of bleeding when you have an anticoagulant on board. It was an excellent talk, and I really recommend that once it's available online to take a look at these education sessions in the ASH education book. I'm sure you'll get a lot more information in the few minutes I can talk on the slides that I've selected. I think one of the take-home messages that is very important that Dr. Siegel put forward is, well, we're all really interested in the new reversal agents and, what to do if a patient comes in bleeding. I think one thing that we always, or not always, but frequently forget is how to prevent the bleeding to begin with. Hospital with a new PE, they're started on anticoagulation. They have all sorts of blood tests done that clearly show frank iron deficiency anemia, and is not even addressed in hospital or written into their discharge summary. And I feel that that's something that we're failing our patients in. So certainly figuring out if they have risk factors for bleeding, addressing those risk factors for bleeding. If they're on dual therapy or triple therapy, as I mentioned, and they don't need it, take them off. If they're on concurrent NSAIDs and they don't need it, try to do some changes in their medications, and really just following them closely and reassessing, educating the patient, as we talked about on the last slide, is very important so they can also participate in their care. So she put a really nice timeline on kind of the steps that we take to reassessing how to restart anticoagulation after bleeding. There's obviously more data that's associated with how we actually do each of these steps that I won't go over in detail today, but it does start with the bleeding has to stop, of course, and then you need to confirm whether the blood thinner is actually necessary, and then you start the whole cycle again of balancing or prioritizing your bleeding and clotting risk, and then deciding whether or not you should restart the blood thinning medication and at what dose. So there are various numbers of guidelines that have come out or guidance statements that have come out on what to do when a patient actually bleeds and whether you should or should not use reversal agents. And this is just one of the examples that has been fairly recently published. Again, really highlighting the first thing you do is obviously support the patient. You're not jumping down the route of reversal agents on the first minute. You want to make sure the patient is stabilized. You want to find the right people to fix and control the bleeding source, transfuse your patient, and so forth. But if they're on a DOAC and a reversal agent is available in your center. In Canada, unfortunately, we don't have Andexanet yet. We're using a 4-factor prothrombin complex concentrate as a substitute, but idarucizumab for dabigatran is available, and certainly using target-specific agents can probably reverse the anticoagulant a bit better, faster, more efficiently than using something that may or may not work. So hopefully one day we will have coverage and approval for all of the specific reversal agents so we can use them as necessary. I think this is either the last or close to the last slide. Again, as a quick overview of the steps that you take after prevention, if the worst case scenario happens and you're bleeding, do your supportive care first. If you have a protocolized way of managing bleeding, it does expedite how you can get things done so people aren't running around in a panicked fashion when it does occur. And then certainly if you have indication for a reversal agent, then you can think about it. But certainly the other factors are just as important. And we like to highlight things because this is a Thrombosis Canada talk, just to reorient you back to our website. It has a lot of great tools on there. It's also an app that you can put onto your smartphones. And there is a bleeding management tool on here that you can click through step by step that gives you a little bit of guidance on how to manage these bleeding events when they do occur. So with that, I don't know if there's time for questions, but if not, we'll be around at the end. Otherwise, I'll pass the floor to Dr. Tagalakis.
Thank you, Dr. Wu. I think it's fantastic. You really have highlighted and emphasized a new knowledge gap, or something that as clinicians we need to pay attention. There's lots of morbidity and mortality after major bleeding on oral anticoagulation. That might be related to us not taking enough precautions or thinking enough about resuming anticoagulation at some point to prevent recurrent arterial and venous event that can lead to morbidity and mortality. So I think it's very, very, very interesting. So we'll keep the questions for the end, and it's a great pleasure to introduce Dr. Vicky Tagalakis. Dr. Tagalakis is an associate professor of medicine at McGill University and an attending physician, Department of Medicine at the Jewish General Hospital. She's the director of the Division of General Internal Medicine at McGill University. She has completed an MSc in epidemiology and biostatistics at McGill University and is a research scientist at the Center for Epidemiology and Community Studies, Levi Davis Institute, for medical research at the Jewish General Hospital. She is well known to all of us. She holds several peer-reviewed grants. She's the co-lead of the Quality Improvement Platform of CanVector. She's a CIHR-funded national research network on venous thrombosis. Vicky, welcome. And
thank you, Mark. So my section will be looking at the perioperative management of thrombosis. In particular, though, perioperative management of the direct oral anticoagulants. So at this year's ASH meeting, although there was quite a lot of information, as we just heard from Cynthia, on how to manage bleeding in patients who were anticoagulated with direct oral anticoagulants, there was a smaller section, but quite significant, vis-a-vis the management of these medications at the time of surgical interventions. And in particular, I will highlight in this section today a poster and a oral abstract that was presented. They kind of shone a bit of a light on usage of an algorithm around the time of DOAC interruption. So the first was a paper poster that was presented looking, in fact, at delayed surgeries due to anticoagulation. So in particular, delayed time to emergency hip surgery in patients taking oral anticoagulants. As we know that hip fractures are quite significant and prevalent in the Canadian population, mostly due to underlying osteoporosis. And it's estimated that there's a total of 30,000 hip fractures in Canada in 2018, with really associated with quite a significant cost to them, exceeding $2.3 billion. Surgical intervention within 48 hours of admission for a hip fracture is considered best practice and has been associated with lower morbidity and mortality. These are emergency surgeries, and there's been a lot of push in Canada and the rest of the world to try to get these patients quickly to surgery, as it has been shown to be associated with a lot less mortality and cardiovascular morbidity. There have been recent studies that have shown that patients taking vitamin K antagonists have longer time to surgery than those not anticoagulated. However, there hasn't been as much looked at vis-a-vis the direct oral anticoagulants, largely because they're actually newer, obviously, on the market for the usage of anticoagulation in patients, for example, with atrial fibrillation, which are the patients also most at risk for osteoporotic fractures. And moreover, these authors wondered, can the same be said vis-a-vis vitamin K antagonists and direct oral anticoagulants, given that direct oral anticoagulants largely have no readily available reversal agent and may, in fact, they hypothesize, may be associated with further increased surgical delays. Moreover, there is quite a bit of controversy or divergent opinions on how best to deal with direct oral anticoagulants at the time of surgery. Although recently, and we'll be discussing this as the second abstract, the PAH study, which was published a few months ago, did provide some guidance as to an algorithm that is gaining increasing acceptance vis-a-vis how to manage a direct oral anticoagulant at the time of surgery. So given all this, given the sparsity of data, these authors wanted to understand more what the impact of a direct oral anticoagulant was to time to hip fracture surgery when compared to patients taking vitamin K antagonists and patients taking no anticoagulants whatsoever. So what they did was they retrospectively looked at all patients presenting to the single center, and in fact this happened to be at the Jewish General Hospital. They looked at this over a 7-year period, and they collected information on over 400 patients undergoing hip fracture surgery, and tried to determine time to surgery in patients who were taking vitamin K antagonists versus direct oral anticoagulants versus patients who were not taking any oral anticoagulant. Now, you need to understand that, as I said earlier, the benchmark is that these patients should go to surgery within 48 hours. The reality is, in the Canadian landscape, only 66% of all patients with acute hip fracture proceed to surgery within this time frame. And it's well published, and it's quite prevalent across most Canadian institutions that even though the benchmark is 48 hours, the median usually is around 66. That's only 66% of patients meet that 48-hour benchmark. So what they found here from a median time to surgery was that patients who were anticoagulant in general took longer to go to surgery than patients who were not anticoagulant. So as you can see, the vitamin K antagonist group took a median of 64 hours. The group that had a direct oral anticoagulant took a median of 61 hours, versus the group that did not have any anticoagulant, they took 44 hours to get to surgery. So this was a statistically significant difference between all three groups. And what's quite impressive is that the vitamin K antagonist group actually also was very similar to the direct oral anticoagulant, suggesting that there are barriers irrespective of what anticoagulant one is taking to hip fracture surgery. And those barriers may be related to the fact that perhaps surgeons or physicians who are assessing these patients for surgery may not recognize that these patients are readily recognize that these patients are taking an anticoagulant, perhaps have not as evident expertise in providing the protocolized way of dealing with these patients. So this was a flag to these investigators who noted this. Moreover, when they looked at this probability of proceeding to surgery on the far right, we note that within the time frame of getting to surgery within the 48 hours, only 24% of the VK group got to surgery within 48 hours, versus 41% of the DOAC group versus 61% of the patients who were not anticoagulated. Now that 61%, as I mentioned earlier, is similar to the national average or quoted average of 66%. So in this institution, the experience for at least the patients that are not anticoagulated is quite similar to what the national average is. All this highlighting the fact that anticoagulant patients are at a disadvantage when coming in with a hip fracture and getting timely intervention to deal with their surgery. Initially, the investigators wondered whether there would be a significant difference between direct oral anticoagulants and vitamin K antagonists, largely based on the fact that the protocolized management of a direct oral anticoagulant is, as I said, quite divergent, and different opinions as to how best to stop a direct oral anticoagulant before surgery and when to resume it. Whereas with the vitamin K antagonist, there's a lot longer experience with these patients, a long history of using vitamin K antagonists. Reversal agents are quite readily available. And so it was quite surprising to see the difference, as I highlighted earlier. So this kind of naturally led us to think about the PAH study. And many of you know about the PAH study, and I'll immediately discuss this with you next. Just to say that these researchers are engaged now to finally determining whether a protocolized algorithm to deal with cessation of anticoagulation as a whole, vitamin K antagonist or a direct oral anticoagulant, should be implemented in their institution, and determining which predictors or what factors perhaps delay surgery is another avenue of research that is being undertaken. So this is naturally then moves on to the study that was presented as an oral presentation at ASH. And this is a natural sort of study, or a second study that came from the study that was published earlier this summer called the PAH study. Which was the perioperative anticoagulant used for surgery evaluation study. And as many of you may know, this was a study that looked at a simplified, standardized pharmacokinetic-based perioperative interruption scheme for patients with non-valvular AFib who were taking direct oral anticoagulants. And the original PAH study looked at the rate of major bleeding and thromboembolic outcomes and did find, and this was published earlier, as I mentioned, in the year, that this management scheme had a low risk of thromboembolic events, as well as low risk of major bleeding around the time of perioperative or around the time of intervention. So how to manage these DOAC-treated patients perioperatively? The second study, the original PAH study, and the study that was presented at the time at ASH looked specifically at the following questions. When is it safe to interrupt? When is it safe to resume? Is heparin bridging needed? Is coagulation function testing needed at the time of surgical intervention? And what we know from the perioperative management of the PAH study, these patients underwent the following scheme. So the scheme differed according to which direct oral anticoagulant the patients were on. And moreover, the scheme differed according to the surgical bleeding risk, whether the bleeding risk was low or high according to the type of surgery. And the final scheme that played a role was the creatinine clearance. So whether or not the creatinine clearance was above 50 or below 50, specifically for the dabigatran group. So once somebody evaluated their bleeding risk, were low versus high for rivaroxaban or apixaban, that determined whether the patient stopped taking the rivaroxaban or apixaban one day before. And if it was a high bleeding risk, then it would stop taking that or rivaroxaban or apixaban 2 days before. Similarly, for the dabigatran, there was the extra stratification that was done depending on the creatinine clearance and whether it's above or below 50, and depending on whether or not, obviously, it's a low or high bleeding risk. And then you can see there that the stoppage depended on whether the stoppage would result in either stopping the dabigatran 1 day before, 2 days before, or 4 days before. The PAUSE study, the secondary study that was presented at ASH, wanted to look at potential predictors of the perioperative bleeding. So the original PAUSE study that was published by Jim Duquetis in JAMA Internal Medicine recently simply looked at what was the rate of thromboembolic events at the time of using the scheme, at the time of surgical intervention and the post-op follow-up period, and what was the bleeding risk. And as I mentioned, these were quite low. But this study wanted to know what were the predictors of those patients that ended up bleeding. And they wanted to evaluate whether residual direct oral anticoagulant levels is a risk factor for bleeding. Once again, we show you here what the perioperative management scheme was. It's sort of a reiteration of what happened pre-surgery, as you can see before the blue sort of time of intervention, day 0 here, and what would happen after surgery. The variation, as I explained earlier, happens before surgery, where it depends on the type of DOAC, the bleeding risk, high versus low, and the creatinine clearance. And as you can see here in this pre and post-operative management, we see that we had a significant cohort of individuals, over 3,000 individuals, mostly split between apixaban and dabigatran. And you can see that the DOAC preoperative omission tended to be for the apixaban low bleeding risk 1 day, 2 days if the bleeding risk was high. Similarly, for the dabigatran group that had over 50 mils per minute creatinine clearance, their stoppage for low bleeding risk was 1 day versus 2 days if it was high, and so on. So in fact, that this graph tells us is that that algorithm that was proposed and needed to be followed in the study was pretty sort of adherent to for all the DOAC groups. And what we see here, the incidence of major bleeding or procedure-associated bleeding, according to the cohorts of apixaban, dabigatran, and rivaroxaban, we see that the 30-day postoperative rate of major bleeding was 0.59% in the apixaban group, 0.91 in the dabigatran group, and 1.27 in the rivaroxaban group. When we look at the high bleeding risk category, we see that the 30-day postoperative rate of major bleeding was 2.96% in the Apixa, 0.88 in the DABI, and 2.95 in the rivaroxaban. So similarly, not surprisingly so, in the low bleeding risk group, the expected rates and the published rates that have been described in the past in the smaller cohorts ranged between 0.5 and 0.9%, and this is what we actually saw in this PAH study, with rates going up to 3 to 4% in prior cohort studies, and similarly seen in this study. These rates were a little bit lower when considering the high bleeding risk category patients. Now, it is true that we had a lot more low bleeding risk category patients than high bleeding risk category patients, but nonetheless, there were quite a significant number of patients that we could still determine some interpretation from the high bleeding risk. Now, the main message from this oral presentation, as I mentioned earlier, was to look at what predictors there were for major bleeding. Because usage of this algorithm, the PAUSE algorithm, that depends on risk of bleeding, that depends on the type of DOAC, and that depends on the cram clearance, is quite useful and provides fantastic guidance for physicians in determining how to manage the direct oral anticoagulant at the time of surgery. But there are nuances, and depending on the type of surgery, nuanced surgery, whether you're undergoing neurosurgical intervention, whether you're undergoing spinal anesthesia, there may be other factors that you'd like to take into effect that may perhaps alter in the future that algorithm that we just discussed. And what they found in their multivariate analysis was that hypertension and active cancer seem to fall to be significant predictors of major bleeding. Specifically, you can see that hypertension had an odds ratio of 3.93, and active cancer had an odds ratio of 2.30. Not surprising when you think about this, that these, hypertension or extreme, malignant hypertension is associated with an increased risk of bleeding, poor wound healing, for example. And we do know from earlier studies that active cancer patients or patients who have advanced cancer or undergoing chemotherapy, for example, they do also have active increased risk of bleeding. Interestingly, in this model, bleeding risk, low versus high, didn't seem to play as an important role as they did in the univariate analysis. The other part of this study looked at whether or not the DOAC level influenced at all the bleeding risk. So I failed to mention earlier that as part of this study, drug levels were analyzed for all 3 direct oral anticoagulants using the anti-10A or the thrombentine for dabigatran, and this was available for around 85% of the patients enrolled in this study. And they considered significant levels to be 50 nanograms or more. And when they did a stratified analysis looking in the patients with 50 nanograms of per deciliter of DOAC activity, they found that the bleeding risk when combining clinically relevant non-major bleeding and major bleeding was around 1.33% for the apixaban group, 2.78% for the dabigatran group, and 5.8% for the rivaroxaban group. Now, these are small numbers, so meaning we don't have a lot of patients who ended up having levels that were over 50 nanograms per mil. So that provides even more confidence in this management algorithm for managing patients around the time of intervention, meaning that if you use this scheme, you should not have that much of a drug level effect measurable in the patient. And nonetheless, we saw that these were bleeding rates, combined bleeding rates of clinically relevant non-major bleeding and major bleeding that were not that clinically elevated or divergent from the original cohort. And when they looked at the multivariable model, adding the DOAC levels to the model, it did not improve the predictability of that model and therefore did not influence or become a predictor for bleeding. So what the conclusions were from this abstract was that the combined major bleeding and clinically relevant non-major bleeding rate was around 3.39% when we combined all the DOACs and we looked at a combined endpoint. And it was very comparable to other prior sub-analyses from the AFib trials, in particular, for example, edoxaban of more late and the rivaroxaban. We talked about hypertension having been identified as a predictor. And that's an important message to take from this, since it could be, and it is potentially a modifiable predictor of perioperative bleeding, and something we as physicians can recommend to our surgeons when dealing with an anticoagulated patient whose blood pressure may not be well controlled. We noted that residual DOAC levels did not improve the predictive model. We note that the pause protocol for DOAC intervention depends on the 3 factors that I already described to you, in particular, the type of DOAC, the type of bleeding risk associated with that surgery, and the renal function when it comes to dabigatran. We noted that close monitoring of patients with prior bleeding and or hypertension is advisable, and by prior bleeding, that is meant the experience of the patient. If the patient has been bled before with this type of surgery, it's something to note when managing your patients. And moreover, that the DOAC level does not seem to be an important predictor, at least in this type of patient population. So I show you this algorithm again because the investigators or presenters at ASH re-showed this algorithm by adding at the bottom, as you can see, gender, cancer, and hypertension, things to potentially consider in the future when dealing with your patients who are on a direct oral anticoagulant and being considered for surgery. Gender is added here. We've talked about cancer and hypertension. The gender, which I didn't discuss earlier, was that when they did an analysis simply looking at major bleeding, not at the combined endpoint of major bleeding and clinically relevant non-major bleeding, there seemed to be a protective effect to being a woman vis-a-vis bleeding. And so that is something that was an interesting thing that the authors came out with. So there are unanswered questions, and that's what the authors ended on, and future potential directions of research. Can we completely forego heparin bridging for patients with a mechanical heart valve? That's to come in the future. We still don't have enough information on those individuals. Can the number of patient groups who don't need interruption be expanded? I mean, ideally, that would be something to favor in patients who are undergoing extremely low risk bleeding type of procedures, such as dental procedures. And does pause provide sufficiently robust findings in high bleed risk neuroaxial anesthesia patients? And that is really where the debate remains, where the controversy remains as to how safe is this algorithm when dealing with, for example, high stakes types of surgery, such as neuroaxial anesthesia, where neuroaxial anesthesia is used. And as we ended in our prior discussions, I just want to point out that on the Thrombosis Canada website, there is a clinical tool that can help you manage the perioperative anticoagulant interventions for your patients at the time of surgery. And it is easily downloadable onto your smartphones and can be used at the bedside readily when seeing or being asked to see these types of patients who will be undergoing some sort of intervention and require your guidance. Thank you.
Thank you, Dr. Tagalakis, for a fantastic overview and new data on how to stratify patients going for a temporary interruption of their direct oral anticoagulants. We'll just move right ahead because we want to have enough time to have a discussion about new guidelines on the prevention and treatment. A couple of guidelines were presented at ASH, and it's a great pleasure to introduce Dr. Jean-Philippe Galanaud. Dr. Galanaud works as a staff physician in the thrombosis team and the Division of General Internal Medicine at Sunnybrook's Health Science Center. He's an associate professor of medicine at the University of Toronto. His medical practice is focused on management of thrombosis and anticoagulant-related issues. He has research interest in venous thrombosis, of course, but with a main focus about distal DVT, superficial vein thrombosis, and post-thrombotic syndrome. It's a great pleasure to have him with us tonight. Go ahead, Jean-Philippe.
Thank you, Marc. So good evening, everybody. So the objective of my presentation will be to provide you highlight on two ASH guidelines that were presented: the prevention of VTE in surgical hospitalized patients and the optimal management of anticoagulation therapy. So the first guidelines are the prevention of VTE in surgical hospitalized patients. So there were 30 recommendations that cover most of the field of prevention in surgery. It's mostly suggestion rather than recommendation. So there is no previous guidelines published by ASH, and so the comparator is mainly the 2012 ACCP guidelines. So in terms of major surgeries, there was no clear definition of what is major surgery in the guideline, but it clearly refers to surgical hospitalized patient as opposed with ambulatory care surgery. So there is, for prevention of VT, two options that are suggested: either mechanical prophylaxis or pharmacological prophylaxis. They mentioned that mechanical prophylaxis is associated with a higher risk of DVT, 6 times higher, but a lower risk of major bleeding, 3 times lower than pharmacological prophylaxis. So if you decide to choose mechanical, if you decide not to go with pharmacological prophylaxis, they suggest mechanical prophylaxis over no mechanical prophylaxis because it is associated with a risk reduction of DVT by 33%. And if you choose mechanical prophylaxis, they suggest that you should use intermittent compression device over graduated compression stocking if available, because intermittent compression device are associated with a 50% risk reduction of DVT and PE. So now, is an option better than the other one? That's the point. And what is new in this guideline is that they suggest to use combined prophylaxis over mechanical prophylaxis or pharmacologic prophylaxis only, because it is associated with less VT event. So that's not something, combined prophylaxis, that most of us do. In Sunnybrook, we do either mechanical prophylaxis or pharmacologic prophylaxis, but the guidelines suggest to do both, particularly in patients at very high risk of VTE. They mention also IVC filter insertion for prophylaxis in patients that have major surgery, and they suggest against IVC filter because it's associated with more deaths, more DVT, and they specify that they do not even comment on the potential harms of IVC filter insertion. What is new in this guideline is that they suggest extended prophylaxis, beyond 3 weeks, over short-term prophylaxis in case of major surgery. And it is based on extrapolation of data of hip and knee arthroplasty and cancer surgery. So they extrapolate the data in those 3 specific subgroup to all patients with major surgery. Now, when we focus on patients with total hip or total knee arthroplasty, they suggest to use pharmacological prophylaxis with either aspirin or anticoagulant treatment. And what is interesting is that we are all aware of EPCAT study. And in EPCAT study, there was an initial course of anticoagulant treatment before starting aspirin. And in the ASH guideline, they don't mention this initial course of anticoagulant treatment. So you should be able to use aspirin right away after hip and knee arthroplasty. When you choose an anticoagulant treatment, you should use DOAC as a first-line preventative anticoagulant treatment because it's associated with a 50% risk reduction of DVT. And if you decide to use heparin, you should use low molecular weight heparin over unfractioned heparin because it's associated with a 50% risk reduction of DVT. They no more mention, as compared with ACCP guidelines, they don't mention warfarin or fondaparinux as a way to prevent VTE after hip or knee arthroplasty. If patients have major neurosurgery, prostate surgery, they suggest against pharmacological prophylaxis, and if you use pharmacological prophylaxis, they suggest using low molecular weight heparin over unfractioned heparin. Now, in trauma patients, it's pretty logical. They state that if those trauma patients are at high risk of bleeding, they suggest against pharmacological prophylaxis, and they state that you should regularly reevaluate the bleeding risk, and you should start pharmacological prophylaxis as soon as it is safe to start. On contrary, when the risk of bleeding is low to moderate, you can go with pharmacological prophylaxis. And they state, and that's a little bit surprising, but they computed data, that in trauma patients, you can use either low molecular weight heparin or unfractioned heparin, keeping in mind that for knee and hip arthroplasty or for neurosurgery, they stated that you should use low molecular weight heparin over unfractioned heparin. So to summarize that, in terms of pharmacological prophylaxis, they strongly suggested in total hip and knee arthroplasty, hip fracture, general surgery, gynecology surgery, and they do not suggest it in case of neurosurgical procedure, total prostatectomy, TURP, and laparoscopic cholecystectomy. As compared with the 2012 ACCP guideline, there is no risk assessment models. They suggest aspirin immediately after hip and knee arthroplasty, and they do not mention anymore warfarin and fondaparinux as a way to prevent VTE. They suggest combined thromboprophylaxis and extended thromboprophylaxis in case of major surgery. Now, I'm going to talk a little bit about the optimal management of anticoagulation therapy. So there were 25 recommendations and 2 good practice statements. And first of all, what about the management of Vicky A? So in those guidelines, they suggest to use, if possible, because of course there is barrier to that, if possible, to use point of care INR testing, and the most preferred option is to use patient self-management, meaning that you educate your patient and the patient realize his point of care INR and then does his own adjustment. The second most preferred option is patient self-testing. The patient does his point of care INR at home and he sends the result to someone who tells him or her how to adapt the dose of his warfarin. They also mentioned that at the beginning of treatment, when the patient is stable, you should monitor your INR every 4 weeks. And when you are on long-term treatment, then you can do your INR every 6 to 12 weeks. Now, what about the management of low molecular weight heparin in obese patients? So they suggest to use actual body weight over capped dose, because if you cap the dose, it is associated with more VTE events, and so it is safer to use actual body weight. Now, is it fair to use anti-10A factor concentration monitoring to adapt the dose in obese patients of low molecular weight heparin? The answer is also no, you should not, because it's associated with more VTE event and more bleeding, because there is a weak correlation between bleeding and anti-10A level. Just use actual body weight to monitor your patient. There was also a mention on whether or not you should use anti-10A levels in patients with severe renal impairment, and they state that you should rather use dose adjust your patient based on the product monogram. Now, should you bridge your patient who have VTE if they are on vitamin K antagonists? If they need to undergo a procedure, should you bridge them? So they made a recommendation of not bridging the patient because it is associated with more bleed and few and uncertain benefits in terms of prevention of VTE. And they, what is interesting is that they define some group at different risk of bleeding, at different risk of thrombosis, and the patient that needs to be bridged are basically those who have a recent VTE event, less than 3 months, who have a severe thrombophilia, either protein C, protein S, or antithrombin deficit, or antiphospholipid syndrome, or multiple thrombophilic abnormality. Those patients need to be bridged, but all the other patients do not need to be bridged. Now, there is a management of life-threatening bleeding. So Cynthia already extensively talked about that, so I will be very brief. If the patient is on VKA, they suggest using PCC over fresh frozen plasma. If the patient is on an oral direct 10A inhibitor, you should use PCC and stop the DOAC. And when andrexanet will be available, then you should be able to use it. If it's a life-threatening bleeding on dabigatran, you should use idarucizumab in addition to cessation of dabigatran because it's associated with less severe bleed than not using it. There was a question of whether or not you should measure DOAC anticoagulant effect when managing DOAC-related bleeding. So when the patient is on dabigatran, you can use thrombin time. When it's rivaroxaban, edaxaban, or apixaban, you should use drug-specific anti-10A activity level. But basically, what the guidelines state is that when you have a life-threatening bleeding, don't waste your time with trying to measure the level of your anticoagulation. Just reverse your patient. Now there is a question on when to restart anticoagulant treatment in a patient who experiences a major bleed and who is on anticoagulation because of prevention of VTE. So they state that you should restart within 90 days because it's associated with fewer deaths. Keeping in mind that, of course, you need to also reassess the indication to anticoagulant treatment because some of the patients do not necessarily need to stay on anticoagulant treatment. And if the patient is on a full dose of DOAC, maybe they can go with low dose DOAC. Then there was an interesting recommendation. It was how to manage a patient who is on DOAC that you want to bridge to switch to VKA. And they suggest overlapping the DOAC and the VKA therapy, and not using low molecular weight heparin or unfractioned heparin, and to do the INR testing just before the next DOAC dose. So to summarize these last guidelines, so they make strong recommendations for INR self-monitoring. They make recommendation against low molecular weight heparin bridging in patients who are on VKA for VTE, except in patients who have recent VTE less than 3 months or severe thrombophilia, including antiphospholipid syndrome. And they also state that low molecular weight heparin should be dosed based on, in obese patients, based on actual body weight, and that you should not cap your patient, and that you should not use anti-10A levels. Thank you very much.
Thank you very much, Dr. Galanaud, for a very elegant talk, and also summarizing well most of the other section that we talked about today. So for the participant, if you have questions, you can put them in chat. And Jean-Philippe, I'll start with you. There's a question just to confirm that the 2 clinical practice guidelines that you've talked about were presented in 2019, not 2018. That's right, correct?
Yes, it's written 2018 for the anticoagulation therapy and 2019 for a surgical hospitalized patient, but they were presented at ASH both.
Correct. Okay, thank you. And then just a follow-up question that, you know, with the recommendation about not capping the dose is something that we do, I think, on a regular basis. We often have this question as a consultant, should we cap it at, you know, to a certain level, depending on the type of low molecular heparin we're using. Do you have a cap in your head? Because we can talk about, like, sometimes we have the 250 kilogram patients, sometimes we have the 300 kilogram patients. Do you always use, you know, weight adjusted dosing, or is there a time where you have a threshold?
No, at Sunnybrook, we don't cap at all. We just use based on actual body weight. But that's our practice. And for sure, I can understand that over a certain weight, you would like to cap your patients.
Okay. And you never use anti-10A level to guide clinical practice based on the recommendation?
I sometimes use it, but I just presented the recommendation. But sometimes, yes, of course, if they are obese, of course, I do it.
Fantastic, because often clinical practice is a little bit different than guidelines too, and sometimes you need some reassurance.
Yes, of course.
Thank you, Jean-Philippe. Question for Vicky. You presented as one of the risk factors, and one of your last slide was gender to predict risk of bleeding for the perioperative interruption of direct oral anticoagulant. Do you have any hypothesis of why that could be?
Yeah, it was actually presented as a interesting variable for the major bleeding analysis, not in the combined major bleeding analysis. And it seemed to be associated that men had a higher risk of clinically relevant non-major bleeding. So it seems to be, you know, we can look at it 2 ways. Why women are protected versus why men perhaps are at a higher risk, especially in the clinically relevant non-major bleeding. And some thoughts have been put forth. Obviously, this was, there are uncontrolled type of other confounders. Not all predictors were assessed. There were low usage of antiplatelet medications, so perhaps there's more antiplatelet medications with men than with women. The type of surgery, there was more excess type of surgery, urological procedures in the men, which would be more in keeping with men than with women. And obviously, for example, prostate surgery can be quite with a higher risk of bleeding. So there may be some unmeasured or not accounted for adequately confounders that could be driving this association.
Right. Oh, yeah, I didn't think of that. It's very interesting. Thank you. Cynthia, question for you. Do you have any word of advice on how to, you eloquently talked about resuming anticoagulation after intracranial hemorrhage. often these types of bleeding happen in less severe bleeding or less critical site bleeding, especially gastrointestinal type of tumors or gastrointestinal type of bleeding. Do you have any word of advice on when do you actually resume anticoagulation in your own personal practice?
Good question. Probably slightly different for a cancer patient, I think, than for a non-cancer patient, as they're a little more complicated. They might have more factors like chemo, if they're due for chemo or surgery or various other things. But I think from the data that we have available to us, there is a bit of a variety, and some of it is statistical calculations more than a clinical kind of guide. But it seems like if you start somewhere around a month to a couple months seems to be a bit more ideal than starting within a few days. For example, it seems that the bleeding risk might be a little bit too high right at the very beginning after an intracranial hemorrhage. But the longer you wait, one, the less likely someone's going to remember to restart, and also the more likely then the thrombotic risk starts to catch up. So I think I've typically probably waited at least a month for these patients. On occasion, if the thrombotic risk is lower, so for example, they had a chronic clot, maybe unprovoked, and you want to eventually get them back on, but it's not that urgent, I might have waited up to 3 months before I reassess the patient. Of course, if they have an acute DVT or acute PE, it becomes a little bit harder. And then I think it becomes very much asking the neurosurgeon or whoever is managing the patient at the time if they can give you a little bit of guidance on what they think the rebleed risk is, because sometimes the bleeding source might be easier to fix, and then you can start a little bit faster. I find that when I do restart, I will frequently, and this is just all expert opinion, use low molecular weight heparin, maybe start a prophylactic dose for a couple of days and then inch it up to maybe a half a dose and then to a full dose. And then if they're tolerating things well, I go back to whatever their previous regimen was. It's a bit more titratable for me.
Right. No, I agree. Sometimes it's easier to try titrate it up slowly over time with a low molecular weight heparin. It's quite convenient that way. And then I kept the last question from Marie-Pierre Arsenault. She's asking, in the cost effectiveness analysis we presented for primary prevention, what's driving cost and why is it cost effective? So it's a great question, Marie-Pierre. The models are quite sensitive to the price of the complication. So if, for example, you're in a setting where you tend to admit more PEs than, sending them or managing them as an outpatient, that will be quite, can make a big difference in the cost effectiveness analysis. The authors have tried to do sensitivity analysis, and the models seem to be quite robust, but obviously the price of the medication and price of hospitalization for complications are a major driver or drivers of cost in these analyses. So I think we went through all the questions. I would like to thank Dr. Galanaud, Dr. Tagalakis, Dr. Wu for a fantastic presentation. I think we all had fun to go to the different presentation, try to see what's interesting, try to provide a nice summary for Thrombosis Canada members, trying to dig up what's new, also what's clinically relevant, but also trying to emphasize a little bit about Canadian data and providing a Canadian perspective. So I thank you for coming in to listen to us tonight. Hopefully this was helpful, and I'll leave the last words to David Airdrie.
Yeah, thank you, Mark, and thank you, Dr. Tagalakis, Dr. Wu, and Dr. Galanaud for your presentations tonight. And I also want to thank Sanofi again for the unrestricted grant for the program. It was a great presentation, and I appreciate everybody's effort and time tonight.